Dr. G. It's 8 a.m. We'll have you start so we can keep this schedule on.
Okay, well, I'm going to talk on geriatric emergencies. I'm proud to be FACP, and I'm even more proud to be AC. Anybody know what AC stands for? Yiddish to cocker, means no shitter, and I'm glad I reached this age already. Okay, so here's my best teacher ever. This was my mother, and even when she was in her 70s, was my best teacher. So what are our goals and objectives here? I'm going to talk about why it's important to know about geriatric emergencies, principles of geriatric emergencies. We're going to talk about some specific acute geriatric illnesses. And because it's supposed to be endocrinology, although I use that to sneak in and give my famous geriatric lecture, I will include some things about endocrine emergencies in the elderly. So why? You see this wonderful woman, you know why you want to take good care of her. Right? Also why? Well, the graying of America. The older population in America is getting larger and larger and larger. In addition, the elderly are special. And finally, there's been studies that show there's a need for education of taking care of older patients. Right? So the elder population in America is growing. The very elderly are the fastest growing population. I had a 101-year-old yesterday in UHB. And even in the whole world, we're seeing something called the silver tsunami, where the older are we're gonna come and take over from you guys, from you youngsters. Right? Also, they use a lot more resources than younger patients. Right? They make up a lot of our ED patients, especially all you need to do is one shift at UHD, and you know that. They're 40% of EMS arrivals. They're sicker. They have more comorbidities. They need a bigger workup. And they have to be admitted more. They spend more time in the ICU, more time in the ED. They have a higher rate of mortality and morbidity. And there are more misdiagnoses and more bounce backs with the elderly. And it can be very hard to make the diagnosis. So sometimes when you're treating these elderly patients with a lot of comorbidities, you are fishing for the diagnosis. So the peds people, young whippersnappers, like to say that pediatric patients are not just small adults. Well, us elderly are not just old adults. Right? We have a different physiology. We have different presentations, including for hypothyroidism, hyperthyroidism, and HHS. We have different diseases like AAAs and temporal arteritis and dementia and diverticulitis than you see in younger patients, including here, this big aortic aneurysm that I had a patient with the other day. And there's some different management in older patients. You have to be more careful, and sometimes you have to start low and go slow, and sometimes you have to be more aggressive. You have to adjust your management. So as you get older, you'll see a lot of changes in the pathophysiology in all these systems, right? You lose your reserve. Also, you're exposed to more illnesses as life goes on. So you're more likely to be sick, and you're more likely to deteriorate faster because you lose your reserve. Right? So what do these pathophysiological changes mean? You're going to see more diseases in the elderly. They're going to need more care. They're more complicated. They're less ability to cope. They have greater severity, and they're more likely to have adverse drug reactions. Right? So why do we need this? There's a study from SAEM a few years back that showed a lot of emergency programs felt they needed more training in taking care of older patients. So we all know about the ABCs. Here's a former colleague of mine taking care of a very sick patient. And obviously, you always start with the ABCs, right? However, I have my own ABCs for the elderly. So A, be attentive and approachable. Always be nice to them and be patient. C, be careful and compassionate. Make sure you don't miss anything while you're being compassionate. And be very sincere and supportive. So anyone who knows me likes to say, be nice. My mother used to say, Joel, be nice, right? And I think that's very important that we be nice to our older patients. So what are some of the principles of geriatric emergency medicine? So their presentation is complex. Common diseases present atypically often in them. They have a lot of comorbidities, and there's a confounding effect of them, harder to make the diagnosis. They may have cognitive impairment, making it harder to get a good history. And they also have a lot of polypharmacy and more likely to get toxicity from drugs. And all of you have seen the brown bag syndrome, right? You pull out from a bag they have, and there's 20 different medicines in them, and including repeats, right? They have this decreased functional reserve, so they crash quickly, and they may need more help, especially social service help. But seeing an older or sick patient in the ER is an opportunity. It's an opportunity to help somebody who really needs it. Right? So what are my important GEM principles, geriatric emergency medicine principles? Right? So they have a lot of comorbidities, so that makes diagnosis and treatment more difficult. Diseases present atypically, so they're harder to diagnose. They have less reserve, so they decompensate rapidly, and you have to be ready for that. And they have an increased risk of adverse drug reactions, right? So what diseases present atypically in the elderly? Well, hypothyroidism, hyperthyroidism, diabetic emergencies like HHS, acute MIs, pneumonia, sepsis, altered mental status, drug reactions, trauma, and acute abdomens. So what about hypothyroidism in the elderly, right? So it's more common. And as I mentioned, they get sicker quicker, so it's more severe. For example, myxedema coma, you almost always see in older patients. And it's harder to diagnose because often their symptoms are very vague: fatigue, weight gain, constipation, which we see all the time. And often there may be neurological changes. They may have depression, dementia, may go on to altered mental status, and even myxedema coma. Signs that may tip you off in the elderly that this might be hypothyroidism is bradycardia, hypothermia, and myxedema. And you want to think about it because the I won't see what the mind doesn't know, right? And if you think about it, you want to get bloods, and especially you want to get a T4 and a TSH, right? And when you're treating them, other than when coma, when you have to be really aggressive and give them IV Synthroid, when you're treating someone with hypothyroidism, you want to start low and go slow. For example, starting with doses of like 12.5 and at most 25 micrograms. Because if you go too fast, you may precipitate an acute MI or atrial fibrillation. So always you have to be careful in the elderly, right? Here's a classical picture of severe hypothyroidism in the elderly. When my aunt, and I talked about this earlier in the year, she developed hypothyroidism and dementia. Well, dementia, she looked kind of like that. And it wasn't until I took a good look at her and saw there was a scar on her neck that I made the diagnosis was probably hypothyroidism. I ran up to Lincoln. I got bloods. I took them back to Lincoln. She had a T4 that was non-existent and a TSH that was off the wall high. right? What about hyperthyroidism in the elderly? How is it different? Well, they're less hyperadrenergic. They're not that wild, kind of sweaty, tachycardic person that we know. But they tend to have more cardiovascular disease because of the hyperthyroidism. So more tachycardia and palpitations, more dyspnea, and weight loss. Those are how it usually presents in the elderly. And they may be apathetic rather than hyper. And they have an increased incidence of atrial fib, CHF, MI, and CVA. So some recommendations are, if you have a patient with new onset AFib, you want to think about getting a T4 and a T3 and TSH. And the treatment initially is beta blockers, but the best drug for them, as opposed to maybe in younger people, is actually methimazole, and then doing radioactive iodine on top of it. But they seem to tolerate that drug better. So another difference than younger people than, say, using PTU. Right? What about diabetic emergencies in the elderly? Right? So they tend to get the hyperglycemic hyperosmolar syndrome rather than DKA. And how is that different? Well, usually they're type 2 diabetics, not type 1 like in DKA. They have very profound dehydration, worse than in DKA, and they tend to have neurological changes. Their sugars are over 600. The last one I had a sugar of 1200. Their osmolarities are way over 320, much higher than you see in DKA. They have no significant ketosis or acidosis. They need more fluids, but less insulin. And in fact, some experts say that rather than our usual 0.1 unit per kilogram per hour on a drip, in these patients, you want to bring them down more slowly. And so they recommend starting with 0.05 units per kilogram per hour so you don't get complications, right? And always look for and treat underlying cause, and a much worse prognosis than DKA, right? Lately, the prognosis for death from DKA is a couple percent. For HHS, it's about 20 to 30%. So again, us older patients, we're more likely to crash and burn. All right, altered mental status, very important in elderly patients and may be missed unless you look for it. Especially the first clue may be a decline in their function. And always think about delirium versus dementia. So dementia is more chronic, but if someone suddenly who's older, and even if they have dementia, deteriorates over a few days, you got to worry now they have delirium. My Aunt Rosie, my great Aunt Rosie, when we were living in Brownsville, and she lived with us, she had dementia. And one day, she started acting different. She wouldn't eat. She didn't recognize my mother, who was taking care of her for years. And then she started running down the steps, trying to go back to her little shtetl, her little Jewish village in Russia. So my mother took her to Kings County, and they admitted her. They admitted her to the psych ward. She died a few days later on the psych ward. In retrospect, she had an acute delirium. It was summer, maybe due to dehydration and heat and infection, right? So there are many dangerous etiology of altered mental status in the elderly. You need to look for it and treat it stat. You don't want to miss it like they missed with my Aunt Rose, my great Aunt Rosie years ago, right? And these are etiologies of acute AMS you have to think about, including endocrine metabolic problems like hypothyroidism and hyperthyroidism and HHS. Right? So trauma is a big deal. And one of the causes of altered mental status in older people I've seen are subdurals. Right? Here's a big subdural. The patient very similar to one I had in UHD a few years back. Right? The elderly more likely to have adverse drug reactions, right? They take more drugs. They get twice as many adverse reactions as younger people. Half of the hospital admissions for adverse drug reactions are actually in the elderly. And when you're treating the elderly, it's always better, unless they're dying, to start low and go slow. Right? Good thing to look up if you're not sure what drugs are safe for the elderly and is the Beers criteria. May keep you from giving an elderly patient a drug that's going to cause a lot of problems that may be non-reversible. Right? And what drugs should you consider avoiding? Things with long half-life, drugs that have a lot of anticholinergic side effects, drugs with narrow therapeutic index. Here are a few examples of drugs you have to be careful with. If you use, you have to be very careful and monitor patients. Right? These are all drugs that can cause delirium in the elderly patients. Right? How about infections? How do infections, why are they different in the elderly? Well, often they may present as an acute confusion or functional decline. You may see serious infections without fever, right? You may see pneumonia without a cough. You may see a UTI without much dysuria. You may see intra-abdominal infection with minimal findings, and they may have a cellulitis and not complain of pain, especially if they have cognitive problems, right? And you always want to look in the elderly who have signs of infection at pneumonia, urine, and the abdomen and the skin. Right? And infections in the elderly are more likely to be bacterial and serious, pneumonia being the most common, UTIs being the most common cause of sepsis. And then always got to look for skin infections and intra-abdominal infections. When I was a medical student, I was doing an ID rotation. We got a consult on the medical ward at Jacobi to diagnose this woman with unknown fever of origin, an elderly woman. I went and I saw her. She'd been spiking fevers for over a week. And when I got close to her, I thought I smelled something. I bribed the nurse's aide to help me roll her. And there in her back was a terrible decubitus, stinking, feculent, and it had to be drained, and she had to be on the proper antibiotics. And I learned a new abbreviation. In the chart, everything was WNL within normal limits. For me, WNL sometimes means we never looked. So you really want to be very thorough when you're examining older patients. You have to look. Right? And they have much more increased mortality. So you want to be more aggressive in finding them, finding these infections and treating them. Right? Look at those mortality figures for the older versus the younger. So who is this good-looking guy below? And what do you think is going on here? Anybody? This is me. I had an abscess and cellulitis on my neck, and I got vancomycin, and what did I get? Got a red man syndrome. So again, I was pretty sick, just from a little cut shaving, typical for the elderly, and more likely to have adverse drug reaction. Right? So when you're treating infections in the elderly, you want to be aggressive with your ABCs. You want to be aggressive in assessing them for where the infection is, and you want to be aggressive with your antibiotics. All right, how about abdominal pain? Much more serious in the elderly, more likely to need surgery and admission. They have 9 times greater mortality than younger patients with acute abdomens. Hard to diagnose them, especially if they have cognitive impairment. Physical exam especially may be relatively benign. So you need often to do more imaging and consults in the elderly. And there are red flags you should be looking for. Any elderly patient with abdominal pain with abnormal vital signs, especially, you always have to beware of resting tachycardia. The most common acute abdomen is cholecystitis. They come in with terrible pain, but you're not getting a lot of abnormal findings when you examine the abdomen. You have to think of mesenteric ischemia. If they have severe back pain with syncope, think of a AAA. And then they also may have referred pain from MI or pneumonias. Again, atypical. ACS, MI, leading cause of death in the elderly. They may not have classical chest pain. They may present with CHF, shortness of breath, syncope, like my father did before he died. And often the workup may not be very diagnostic, but you want to be careful and not just say, oh, a first troponin negative, I want to send them home, right? This is a case that I had in the elderly, came in with just GI symptoms and vomiting. And when we got the EKG, looked like it was a GI problem. It was a big inferior MI, right? So trauma is an important cause of mortality and morbidity in the elderly. They don't do well when they've had significant trauma. And a lot of studies show they deteriorate more rapidly than other people would with the same trauma. Most common cause is falls. And you always want to ask yourself, why did they fall? You always want to ask about the mechanism of injury. And then obviously you still use the basic principles of resuscitation. And you want to watch them very closely because they may deteriorate very rapidly. And they may not be tachycardic because they're on beta blockers. And they may have cognitive impairment and can't tell you what hurts. My Aunt Frida, she was living in an assisted living facility. She had bad COPD from 75 years of smoking Camels. One day, she tripped over her oxygen line, broke her hip, and broke her tib fib. Had to have surgery, went into CHF during surgery. Also, on top of that, got pneumonias and died in the hospital. So falls, and especially fractures from falls, hip especially, can have much more higher morbidity and mortality in older patients. Right? Always also consider abuse and neglect. What are those? Anybody? Maggots. Right? And always think about social issues, right? End of life issues. Prior to discharging them, evaluate the home situation. Right? Get nursing and social service to help arrange good follow-up. Report suspected abuse and neglect, and don't send them home if it's unsafe. I've had many fights with the care management people at Downstate because they wanted me to send home some older patient who I felt was unsafe to go home. So you have to be the advocate for your elderly patients. Right? So don't send them home like this. Right? So in summary, know the principles of geriatric emergencies. Right? Gernsheimer's 4 gems. No specific illnesses in the elderly. Be careful when you're evaluating and treating them. You don't want to miss anything. and always do the right thing for our older patients. Here are my references. Here's my favorite references at the bottom. Two really good-looking older guys. Myself and Dr. Sinnert had a chapter in this geriatric emergency medicine clinics in geriatric. And thank you, Dr. Sinnert, for including me in that chapter. How could you not want to do well by these patients, right? This is from Haiti. Any questions?